Welcome to the Urology Medical Coding Masterclass. Today, we're kicking things off with Part 1, Anatomy Foundations and Clinical Coding Logic. To become a truly authoritative surgical coder, you simply can't just memorize a list of CPT codes. You actually have to understand the human body exactly the same way a surgeon does. Because at the end of the day, accurate reimbursement and strict compliance, they completely start with exact anatomy. So, let's dive right in. Here's a quick look at our roadmap for this session. We'll start with how anatomy drives coding, map out the urinary tract, do a deep dive into the prostate gland, explore clinical pathways, and then wrap up with a summary and next steps. All right, Section 1, Anatomy drives coding. So there's a golden rule here, and I want you to literally burn this into your memory. Code selection is strictly driven by anatomical site, surgical approach, and whether the procedure is diagnostic only or therapeutic. Every single coding decision you make begins with pinpoint anatomical precision. If you don't know exactly where the surgeon is working and what their ultimate goal is, well, you simply can't assign the right code. It's really that simple. Moving on to Section 2, the urinary tract. Okay, look at this. To really master these codes, we need to visualize the top-down physiological flow of the urinary tract. Imagine starting way up high in the retroperitoneal space with the kidneys. From there, urine travels down through the ureters, pools into the bladder, and finally exits through the urethra to the outside world. This map right here, it's your ultimate guide for reading through every single surgical report. Let's break down these 4 key landmarks. First up, we have the kidneys. Their whole job is to filter out waste, ditch excess fluid, and produce urine. Second, the ureters. Think of these as muscular transport tubes moving urine from each renal pelvis straight down to the bladder. Third is the bladder itself, which is basically a highly distensible storage reservoir holding onto urine until voiding. And finally, the urethra, the final conduit expelling urine outside the body. Figuring out which specific step the surgeon intervened on, that's actually your very first major branching path in the CPT manual. Now here's where it gets interesting. While the upper tract is pretty much identical between males and females, the lower urinary tract has some stark anatomical differences. For instance, the male urethra is much longer, having to navigate right through the prostate and the penis. The female urethra, on the other hand, is shorter and entirely separate from the reproductive tract. Why does this matter to us? Because these anatomical variations completely alter the surgical approach, the procedural complexity, and ultimately your code selection. Which brings us perfectly to Section 3, the prostate gland. When it comes to the prostate, its clinical significance really all comes down to real estate. Notice how the gland sits directly below the bladder neck? It literally physically encircles the prostatic urethra. It's wrapped right around the conduit that drains the bladder. Honestly, just wrapping your head around this physical positioning is half the battle in urology coding. So just to recap the anatomy and physiology real quick, the prostate is right below the bladder, surrounding that prostatic urethra, and its main job is to secrete fluid that forms part of semen. But clinically, its highly vulnerable location is the big issue here. Because it completely hugs the urethra, anytime there is benign enlargement, inflammation, or a tumor, it immediately pinches that urinary pathway, and that causes severe obstruction. Frankly, that is exactly why urologists are operating on this gland so frequently. All right, Section 4, Clinical Pathways. This is where we connect the dots between the diagnosis and your coding strategy across 3 totally distinct clinical pathways. Pathway 1. Let's say we have benign prostatic hyperplasia, or BPH, causing an obstruction. That routes you straight to endoscopic resection, enucleation, or vaporization. So think of your TURP, HOLEP, or green light procedures. Pathway 2. What if you have a massive benign obstructing gland that's just way too big for a scope? That routes you over to an open or robotic simple prostatectomy. And then pathway 3, say the patient has an elevated PSA, suspicious lesions, or confirmed prostate cancer. That strictly routes you to a TRS-guided biopsy or a radical prostatectomy. Listen, I absolutely cannot stress this enough. We are talking about the exact same gland, but you have 3 completely different clinical stories going on. BPH, a massive benign gland, or aggressive cancer. Those underlying indications are what strictly route you, the coder, into 3 entirely distinct CPT procedure families. Understanding this tight interplay between anatomy and the disease process, that's your golden ticket to clean claims and rock-solid auditing compliance. And that brings us to Section 5, Summary and Next Steps. Let's quickly review our main takeaways from today. First, anatomy strictly dictates coding. You've got to always pinpoint the site, the approach, and the intent. Second, remember to visualize that top-down urinary flow. It's going to ensure you land in the correct section of the CPT manual. And finally, the diagnosis routes the procedure. Nailing down the specific anatomical landmark and understanding the why behind the surgery is exactly what routes you directly into the right coding family. So, you've now got the solid anatomical foundation needed for high-level surgical coding. But what's next? Well, in part 2, we're going to take all of this and apply it to diagnostic versus therapeutic cystoscopies. We'll be navigating through some really complex operative notes, biopsies, and stent placements. Trust me, you absolutely don't want to miss it. Like, share, subscribe to Decode Healthcare with Harshal.